I'm Dr. Twyman. I'm a board certified cardiologist, and I focus on the early detection of subclinical atherosclerosis. So basically, I help people not have heart attacks and strokes. So if you don't have time to die and you want to become heart attack proof, I'm your guy. So I started Apollo Cardiology back in August of 2019 to be able to focus on detecting subclinical atherosclerosis at the earliest stages. I'm an invasive cardiologist by training, so I've done hundreds, if not thousands, of heart catheterizations and treated many people with heart attacks. But I always felt that there's a different way to treat people instead of just waiting for them to actually have an event. So you want to meet your cardiologist 10 to 20 years before you're laying on that cath lab table getting a procedure done. And so I'm going to help teach you to understand what test to ask for with your doctor. So where does my journey begin? Well, I finished my cardiovascular training back in 2012 and have been practicing general cardiology and then some functional integrative cardiology since about 2014. But back in 2017, I decided to take a trip over to Asia to go visit Bhutan, where apparently the happiest people in the world live. But from where I live in St. Louis, Missouri, it was about a 14-hour flight. So I knew the jet lag would be pretty severe when I traveled there. So I was researching some tips and tricks on how to mitigate the jet lag, where then I stumbled upon the blue blocking glasses. So at that point, I purchased the glasses, did not understand how they worked, but was told that if you wear them on the plane, your jet lag won't be that bad. So this was literally the picture I took on the plane, looking just like the Unabomber. And miraculously, I didn't get kicked off the plane. But when I got to Asia, I had jet lag, but it was approximately 1/3 as bad as I expected. So I enjoyed my trip. And then when I got back home, went deep down the rabbit hole of how circadian biology really works. And to this day, if I'm in front of technology that's emitting blue light, I'm protecting my eyes with different blue blocking glasses because it really helps optimize my circadian rhythms and ultimately my sleep, which I'm going to teach you is critically important if you don't have time to die. So what is our agenda today? Well, we're going to be talking about the crucial test to determine if you have early atherosclerosis, plaque in the arteries. We'll be talking about what you can do to prevent having a cardiovascular event, a heart attack, or stroke. I will discuss the actual truth behind cholesterol, statins, and their impact on your overall performance. And then ED equals ED. So erectile dysfunction equals endothelial dysfunction. We'll be touching on mitochondrial health. That's what that is, a giant mitochondria. It's so important that I put it on my wall in my office. And we'll be discussing photobiomodulation, colloquially known as red light therapy, but there are other colors or wavelengths of light that also provide photobiomodulation. So how do you not have a heart attack? First, test, don't guess. So unfortunately, half the time somebody has a heart attack, they had no symptoms before a plaque ruptures. So it's not so much like you poured bacon grease down the drain and filled up full of sludge in your artery. It's something happened to your arterial wall. Something scratches up the endothelium, which we're going to discuss in a moment. Inflammation occurs in the artery wall, and then the cholesterol-containing lipoproteins deposit their payload in the arteries, and this kicks off an immune response. These plaques can go undetected for many years, and the body will keep trying to scar it down, eventually may even calcify it. But if the plaques are allowed to rupture, the blood will clot, and when the blood clots, it restricts blood flow downstream, so the tissues will start to die. If this happens in your heart, that's a heart attack. If it happens in your brain, that's a stroke. So you have three main coronary arteries on the outside of your myocardium or your heart. So you have a right coronary artery, which wraps around the side and hits the bottom part of the heart. You have a left main coronary artery, which has a branch going down the front of the heart called the left anterior descending artery, sometimes colloquially known as the widowmaker, because if you have an occlusion acutely in this artery, it's often fatal. And there's also a circumflex artery, which wraps around the side of the heart and goes to the bottom. But your arteries are, in ways, sort of like a garden hose. So those looking down the barrel of the garden hose. So this part here is the lumen. This is where the blood is flowing. We're concerned about what's going on in the artery wall. The plaque typically first grows in the artery wall, kind of like an iceberg below the surface, and then eventually the iceberg tip points up into the lumen and can start obstructing flow. But at this stage, the plaque is maybe a 30% plaque. The person's going to have no symptoms, even if they're exercising. So you have to go doing other tests to look at the health of the arteries because symptoms aren't always going to be present. So as I just said, unfortunately, 50% of patients who have a heart attack or stroke, had no symptoms before they had that event happen. But those people also may have, quote, normal cholesterol levels. So cholesterol is not necessarily the boogeyman put into you to give you a heart attack or stroke. Cholesterol is critically important at making your hormones, your testosterone, Your bile acids to digest fat. It makes your cell membranes. So without cholesterol, you're not alive. But we'll go into what you really need to be monitoring on lab work. There is really no such thing as good cholesterol or bad cholesterol. They wanted to make it simplistic and call LDL lousy and HDL happy, but cholesterol is just cholesterol. There's different lipoproteins that ferry the cholesterol through the system, and some of those are, quote, more bad than others. So often, people will look at their top 5 risk factors, those being, do you smoke? Do you have diabetes? Do you have high blood pressure? Do you have high lipoproteins? Are you obese? Those are pretty straightforward risk factors, but there's approximately 400 risk factors that can damage your arteries. And if you don't look for these things, sometimes you're going to get surprised. So you can look at different inflammatory markers, such as high sensitivity CRP, Lp(PLA2), myeloperoxidase, F2-isoprostanes, which is a urine marker, homocysteine, uric acid. The lipoproteins are what actually ferry the cholesterol through your arteries. So the main one you want to look at from the LDL family is going to be apolipoprotein B, or ApoB for short. In 20% of the population, they will have a lipoprotein that is known as Lp(a), or Lpa for short. This is a number 1 genetically inherited lipoprotein that increases the risk of early cardiovascular disease. Bob Harper, the gentleman from The Biggest Loser, had a heart attack at age 52. He did not know that he had this lipoprotein, and without the benefit of having a bystander do CPR on him when he had sudden cardiac death in the gym, he would not be here today. So you should at least get your Lpa checked one time in your life to know, do you have high levels of it or not? Then, are you metabolically healthy? Cardiometabolic fitness is extremely important to health span and longevity. So you're going to want to know what are your fasting insulin levels, fasting glucose, hemoglobin A1C, which is a rough estimate of your 90-day average blood sugar. But you can also do a continuous glucose monitor to see your day-to-day fluctuations in blood sugar. You also want to make sure that your immune system is kind of perfectly regulated. When you have an infection, you want your immune system to kick on. You don't want your immune system turned on all the time attacking yourself. One of the common places that the immune system will start over producing antibodies is towards the thyroid. So do you have Hashimoto's or autoimmune thyroiditis? You can assess that with blood work. Vitamin D is critically important for hundreds of reactions in the body. It's the sunshine hormone. It's not a pill that you take. What is your omega-3 status? So you want to know how much EPA and DHA you're absorbing from your diet. Those are found mainly in cold water fish. And I mentioned previously in some of the inflammatory markers, homocysteine, uric acid, those have an effect on nitric oxide, which we're going to talk about shortly. And then asymmetric dimethylarginine and symmetric dimethylarginine, they also have an effect on nitric oxide. Nitric oxide is a critically important molecule, as you'll see coming up. And then genes do play a role in increasing cardiovascular risk. There are many genes that can do this, but the top ones that I typically will check in people is ApoE. If you have an ApoE4 genotype, that increases your risk of early cardiovascular disease, as does the 9p21 gene. This is colloquially known as the heart attack gene. And then KIF6 can increase your risk of cardiovascular disease and also aortic aneurysms. So heart disease is about endothelial dysfunction initially. So if you have endothelial dysfunction, things are going to be sticking to your arteries and you're more likely to develop a plaque. So you have one cell lining the endothelium. The lumen of your artery is where the blood flows. We're concerned about also what can have access to the underlying area of the intima and then the adventitia. The endothelium, if you laid it all out, would be the surface area of 6 tennis courts. It's actually up to 60,000 miles of length in your blood vessels. Your endothelium can start getting impaired in your teenage and 20 years, and this is the first sign that something's going wrong with your arteries. So I recently had given a talk to physicians about the story of the endothelial glycocalyx. This is something that's being discovered in the 1960s, but is only now really getting more clinically evident that this is the real root structure that you need to address to reduce cardiovascular events. So the glycocalyx actually protects that underlying endothelium. It looks like little hairs, or sometimes I teach people that it looks like kind of like grass at the bottom of a riverbed, and it's sensing what's floating through the blood. So in this picture, this is a artery cut in cross-section, and this little fluffy sugar coating is the glycocalyx. There are proteoglycans, glycoproteins, glycosaminoglycans in this, and then some soluble proteins. But it's critically important for coagulation. It's critically important for the immune system. It's also a pressure sensor. So when the blood is floating through here, this coating will send a message down to the underlying endothelium that, hey, a lot of blood is coming by. The nitric oxide will be produced in the endothelium, and nitric oxide will then cause the artery in the wall to relax. That improves blood flow. Nitric oxide also tends to prevent the white blood cells, the platelets, the lipoproteins from sticking to the artery in the first place. So sometimes I say, the endothelium, the glycocalyx is kind of like a tennis net. Certain things are supposed to be permeable and able to get through it, but not everything. So, this is a good analogy that, particles that are heavily negatively charged tend to slide on right by. Particles that don't have a charge tend to get through the gaps. So one test that you can assess to see how healthy are your arteries is a test known as the EndoPap. So it's a non-invasive test. It takes 15 minutes to perform. It's assessing the flow in your fingers. So you have a probe on each index finger, and you do a 5-minute warm-up. It kind of looks like a little seismograph measuring the flow, and one arm acts as the control of the other. Then you pump up a blood pressure cuff, and that temporarily cuts the flow to that side. You may get a pins and needles sensation in the hand, but it's not dangerous. The other arm continues to act as a control. And then after 5 minutes, you open up the blood pressure cuff, and you get what's known as reactive hyperemia. So as that blood rushes back down into the hand, that blood is going to transduce the glycocalyx. Basically, it tickles it. That transduction sends a message to the underlying endothelium. Then the endothelium is going to pump out nitric oxide. That nitric oxide is going to dilate the blood vessel so that the flow comes down into your hand and your hand wakes back up. The test will give you a number known as the reactive hyperemia index, or RHI for short. The higher that number, the better the arteries are when there's a vessel stressor. Ideally, your artery should double in size when this stressor is present. Optimally, it would triple or quadruple. But if it's under 1.68, meaning your arteries can only dilate 6 to 8%, you have endothelial dysfunction. And you're set up to potentially developing plaque in the arteries if you don't fix that endothelial dysfunction. So it was Dr. Thomas Sydenham in the 1600s who had a quote, "A man is as old as his arteries." So there's a test called the carotid intimal medial thickness scan. It's an ultrasound that's non-invasive, and it will assess the thickness of the layer under the endothelium that is known as the intima. So the person on this side has normal carotid intimal medial thickness. So that tends to mean that whatever's floating through the blood is not sticking to the glycocalyx and getting retained under the endothelium, causing inflammation. This person tends to have inflammation in the artery where the intima is increased. So thicker arteries tend to go along with more plaque in the arteries. So this test will also give you a score known as your vascular age. So if you're biologically 50 years old, but your arteries are 70 years old, you're aging faster than your birthday age. And you want to do the advanced blood testing and some other markers to figure out why are your arteries aging faster. But it always generally starts with endothelial dysfunction, followed up by inflammation. So a test I routinely recommend to my patients that are over the age of 40 who have not previously had an event, meaning you've not had a heart attack, you've not had a stroke, is a test known as a CT coronary calcium scan. It's basically like a mammogram for the heart. It's looking for disease at the earliest stages before you have symptoms. So calcium obviously is supposed to be in your bones and your teeth. It's not supposed to be in your arteries. Calcium in your arteries is indicative that plaque is building up in your arteries, and the body's causing it to scar. The calcium isn't necessarily the problem. It's what comes with it. It's the softer plaque. So higher calcium scores, higher risk of having events. So this picture indicates kind of what it looks like to get a calcium score. It's a dry scan, meaning there's no IV required, there's no contrast, and you basically go into a tube, hold your breath for a couple seconds, and you take a quick scan of your heart. So the reason I showed the picture of President Clinton and the astronaut is that President Clinton was the last president not to get a calcium scan. He had passed all his executive presidential physicals every year, including stress tests. But only a couple of years out of office, he ended up showing to the hospital with angina and was discovered to have multivessel coronary artery disease, leading to bypass surgery. So how did he have severe coronary disease in his arteries that didn't get picked up on a stress test? Well, stress tests really only will pick up severe disease. So you generally have to have a 70% blockage or stenosis in your artery before a stress test is going to trip abnormal. So this is why people can pass stress tests and have heart attacks. Stress tests are really good at picking up symptoms. So if you have chest pain with exercise or shortness of breath with exercise, or you just can't exercise the way you used to think you should be able to, the stress test can help unmask that if it's positive. But the negative stress test doesn't tell you too much about if you're really low risk of having a heart attack or not. You have to do these further tests to look at the actual artery walls. And also the reason I show the picture of the astronaut is that, I believe there might be some people grandfathered in, but it's my understanding is that any new astronaut that's planning to go to space has to have a calcium score of 0 because there's no cath lab in space. You have a heart attack in space, you're kind of on your own. So the general recommendations are that asymptomatic males without known coronary disease should get a calcium score test after the age of 45. I personally do it generally under 40. Rarely will do it under the age of 40 unless somebody has a very strong family history, and mom or dad or siblings at an earlier age. Women tend to have coronary disease about 10 years later than men, probably because of the protective effects of estrogen. But the guidelines say 55 to 75, but I still will treat women generally between 40 and 45 is their first scan. Again, it's kind of like a mammogram. The sooner you can find it, if there's high risk, the better the outcomes tend to be. And then, if you're under that limit, again, it's more kind of you have severe dyslipidemia, diabetes, you're a smoker. Okay, maybe you're going to screen people under that stage. And that was me in the day about going into the cath lab to do one of these procedures. So again, you don't want to meet your cardiologist on the way to this cath lab. So what are the odds you're going to have an abnormal scan? So generally, 60% of people are going to have a score greater than 0, meaning it's pretty common. Now, the higher the score, the higher the risk. So if your score is over 400, that is considered high risk. And up to 1 in 6 people will have a score over 400. Over 1,000 is very high risk. 1 in 29 people will have that. What's the highest score I've ever seen? Well, it was actually not that long ago. It was somebody who had a score of 7,700 plus. That person had multivessel coronary disease on angiogram and got multiple stents. He was not highly symptomatic and was reportedly able to do multiple Peloton rides a week without much symptoms. So again, if you don't test, you don't find these things. But a new kid on the block is the clearly CT coronary angiogram. It's a more sensitive test because it will actually be able to also see the soft plaque in the arteries. So it has some cool 3D images, but it's basically going to be able to quantify how much of the plaque is calcified versus how much of the plaque is low density versus how much of the plaque is low density and more necrotic, meaning it's more likely to rupture. So that's the benefit of doing the CT angiogram. The test looks kind of like a roadmap. So it takes an artery that, is in 3D, looks like a big C, and it stretches it out like a road. So in this portion of the vessel, this is where the lumen of the artery is, where the water or the blood is flowing. And then the black is the myocardium or the heart tissue. So this person has a couple minor plaques building up in their circumflex artery. They're not going to feel these plaques. The plaque is building up only in the wall of the artery, kind of like an iceberg. It's below the surface of the water at this point, so it's not obstructing flow significantly. But these plaques, if left unchecked, could grow into a problem for this person. Right now, there's no calcifications in the plaques, so the person's calcium score test would be 0. But they do have some of this softer plaque, and the goal is to stabilize this plaque so it doesn't get any worse, and ideally see the plaques delipidate or shrink down. So the test gives you quantified data, tells you exactly how many millimeters cubed a plaque that's present. I'll go over the kind of the scoring algorithm in just a moment, but it lays it down, how much of the plaque is calcified, how much is non-calcified, and how much is the low density non-calcified plaque. And that's tend to be the more dangerous plaque. So in this individual, their total plaque volume was 200.3 millimeters cubed. Not a lot of low density plaque. Most of it is non-calcified plaque. And at this point, again, they don't have any calcified plaque. Now, the percent atheromal volume was a little bit increased. This is essentially, if you look at, a garden hose and you chop in half, how much of the wall is filled with plaque? Well, 9.6 of this artery is filled with plaque of the wall. The person has no severe stenosis. So general stenosis greater than 70% is considered severe. And these are the people that tend to have symptoms, especially upon exercise. These are the people that will fail a stress test. But half the time people have heart attacks, again, their plaques are 50% or less often. So anytime you find plaque, you want to be aggressive at stabilizing that plaque. This person's not going to need a stent. They're not going to need bypass surgery, but they need aggressive lifestyle management, supplementation, and potentially medications. So staging atherosclerosis. So clearly actually has a article out in the Journal of Cardiovascular Computed Tomography that lays down the reasons why it's important to actually look at plaque, because the higher the plaque burden, the more major adverse cardiac events, meaning more heart attacks, more cardiovascular deaths. So the staging algorithm breaks it down to 0 total plaque volume, which I've seen twice in my career doing this test. It's very sensitive. So when other tests are, quote, normal, you will often find plaque on this test. So the majority of my patients are showing up with mild plaque, where their score is less than 250, such as that previous individual. They give some suggested, medical therapies. I do things a little bit more aggressively than this, but it's mostly looking at the plaque volume. And I've had a couple of people with severe plaque greater than 750. So they're being very aggressively treated with pharmacological agents to kind of put the 5-alarm fire out in their arteries. So sometimes that tool is statins, but it's a tool that you want to make sure that it's used in the correct individual. So there's always risk versus benefits of anything that you put into your body. Now, primary prevention is when somebody has never had a heart attack or stroke, or never had a stent or bypass surgery. Are statins right for them? Well, if you have a clearly scan that your total plaque volume is over 750, you're pretty high risk, even if you've not had an event. Statins are probably the right tool. If your total plaque volume is 0, then no, you don't have evidence of any plaque buildup at this point. So maybe statins aren't the right tool in that individual. Now, secondary prevention is you've already had a heart attack, a stroke, a stent, bypass surgery. Statins are always going to be standard of care in first-line therapy. But cholesterol is, again, not the problem. It's the lipoproteins ferrying the cholesterol through the system that are the issue. So there's no such thing as good cholesterol or bad cholesterol. And you really need to look at the particles. So you can look at the LDL particle count, or you can look at apolipoprotein B, or ApoB for short. Either the CT coronary calcium scan or the clearly CT coronary angiogram will guide you how aggressive to be with lipid-lowering therapies. Now, can you get myopathies with the statins? Of course you can. So up to 10% of patients on statins report having adverse muscle symptoms, SAMs for short. Symptoms can be myalgias, myopathy, which is weakness. They can have cramping, flu-like symptoms. Their muscles may be tender. They may have, quote, joint pain. People who tend to have more of these symptoms are the women, older patients, people with kidney disease. Those are the people that you see this more often. And then there are certain people with certain SNPs that have more symptoms. People with ApoE4 genes, CPT2 genes, and especially SLC01B1 genes can have more of the statin adverse muscle symptoms. A very rare, and fortunately very rare symptom can be rhabdomyolysis. This is the most concerning muscle effect. It's when your creatine kinase levels are upper levels of 10 times of normal. This is when the muscles are actually breaking down and they're spilling out this creatine kinase into the bloodstream. So fortunately, it's only 1.5 people out of 100,000 people that have this. Back in my day when I was a internist for the Navy, I would see often episodes of rhabdomyolysis in the Marine recruits when they're out exercising in the heat in Paris Island. They'd have creatine kinase levels in the tens of thousands at times. So I've seen multiple cases of rhabdomyolysis, but knock on wood, I've never seen one due to statin use. But if you have muscle symptoms when on statins, what could you do about it? So symptoms usually resolve when stopping the statin. The symptoms go away within 2 to 4 weeks. But you can change the class of statin. You can go from a fat-soluble statin to a water-soluble, or go the other way around. You can decrease the statin dose. You can potentially do certain statins twice a week that have the longer half-life. There's non-prescription options now. Those would be things such as bergamot, berberine, omega-3, fish oil, niacin possibly. And then there's other prescription lipid-lowering therapies. There's bempedoic acid, which is known as Nexletol. There's fibrates. There's ezetimibe, also known as Zetia. And then there's the injectable PCSK9 inhibitors, Repatha and Praluent, which have very potent ApoB lowering properties. But other things you can do to lower muscle symptoms from statins is optimize your vitamin D status, Ideally, I like to generally see levels between 50 and 60, but that's with the caveat of using sunlight to sulfate the cholesterol in your skin and have a vitamin D level of 50 to 60, and having optimal thyroid function. Um, you need to check not only TSH, but your free T3 and free T4 and make sure those are all in optimal ranges. And then there is some potential benefit of being on coenzyme Q10. Coenzyme Q10 may help with muscle symptoms as well. So as I previously said, ED equals ED, erectile dysfunction equals endothelial dysfunction, can happen in up to 10% of the population under the age of 40, and it's 50% of the time in people between 40 and 70 years old. There's often medical causes that can contribute, including prostate surgery and spine surgery, but sometimes in patients that are treated with beta blockers for high blood pressure, heart rhythm issues, it's the beta blocker contributing to it. So try to figure out if there's another agent you can use, possibly calcium channel blocker. But alcohol definitely can be a contributor to erectile performance issues, psychological issues, including PTSD, depression, anxiety, where counseling is the first line treatment. But unfortunately, and often more than half the time, it's a vasculogenic cause. It's a blood vessel flow issue. And the reason I show the Mike Myers, Austin Powers video of him using a pump is that the pumps help bring blood flow to the penis, and that can help maintain erections. There is a device in the market that's kind of like the little brother to Gainswave therapy, shockwave therapy. It's not actually electricity, it's sound wave. It's 20,000 hertz sound waves. Those sound waves can help improve angiogenesis, basically help regrow blood vessels to the area treated. So sessions can be done at home. Generally, it's twice a week, and people will have up to a 50% response rate at 6 months. So it's a non-drug option to treating erectile dysfunction at home. The pumps work synergistically. It again also stimulates blood vessel growth and nerve growth, generally twice a day for 10 minutes, and every day for 6 weeks is the ideal treatment protocol. It helps stretch the skin, and it's basically exercise for the penis. And it's going to improve the endothelial function. It's going to help the body make nitric oxide. So now we'll switch over to mitochondria. Mitochondria, again, like what's on my wall, are the organelles in your cells that make energy for you. And it's estimated that up to 80 to 85% of chronic diseases are due to having dysfunction in the mitochondria and their ability to make energy. So this is my quote, we all have the same amount of time in the day. We don't have the same amount of energy. And it comes down to what can the mitochondria do for you? So your heart is a muscle, much like your bicep and quadricep. And the mitochondria, when they're dysfunctional, will contribute to the heart becoming less effective at pumping and also less effective at relaxing, diastolic heart failure. So it actually takes more ATP and energy to relax the heart than it does to contract it. So this is where potentially photobiomodulation can come in. So using light therapy to change your biology. So this is an example of one of the full body panels made by company Thor. Many of the sprinting team on America, were using this in the Rio Olympics, and the athletes that tended to use therapies to recover tended to do better. So you can use this before exercise, generally up to an hour before exercise, and you'll have greater endurance. If you use it after exercise, decreases inflammation, and generally you can recover faster, so you can hit it again hard in the gym or wherever you're doing your exercise. So I've done some out of school training to learn a little bit more about photobiomodulation. So we have a lot of food gurus in the world. We don't have enough light gurus because it really does start with light. So we've all seen a rainbow, hopefully, in our life, and you can see that there's different wavelengths of light in a rainbow, the red, yellows, greens, and blues. But it's mainly the red lights that are impacting as well as the infrared light. So generally between 620 and 700 nanometers is the sweet spot for the red light therapy to be affecting the mitochondria. So what happens when light hits the body? The acronym is RATS. It can reflect or basically bounce off the skin, and up to 2/3 of the light just bounces off the skin. The light can be absorbed in the cell, kind of like Pac-Man eating the photon. The photon can pass through the system and transmit, basically like an X-ray, or it can scatter. So the photon comes in, bounces around, and either gets absorbed or it ultimately passes through and is transmitted. So the benefit in the mitochondria is that the red photons of light and infrared, it's absorbed by cytochrome C oxidase, which is the fourth step in the electron transport chain. So your mitochondria are taking your carbohydrates and fats, breaking it down into electrons to funnel through this electron transport chain. But when the cytochrome C absorbs the red photon of light, nitric oxide will be released. That can help dilate blood vessels and push oxygen further down into the cells. It will decrease reactive oxygen species. Basically, it's going to lower your body's ability to rust from the inside out, and it's going to increase ATP, the energy currency for the body. So here's a picture of the electron transport chain, kind of like a game of hopscotch. The electrons are hopping through the different cytochromes, and the photobiomodulation is acting right on this fourth cytochrome. So when this is stimulated, then energy can flow, or I should say electrons can flow to the ATPase, which is kind of like a spinning top. The faster the spinning top goes, the more ATP comes out the other side. So there's a great book by Dr. Gerald Pollack called The Fourth Phase of Water. If you want to understand how structured water or easy water is actually formed by photobiomodulation. But the short story is that when infrared light hits water, it's going to charge separate it into negative and positive charges. And that's a battery. They've actually been able to take water, put certain wavelengths of light on it, put probes into the negative and the positive areas of the water, and actually light up light bulbs. So this is potentially how your body also stores energy. The body may not run just on ATP. So often when you go to the beach and you soak up a lot of sun, this is the reason why you may feel better or maybe not have as much of an appetite, because your body literally can make energy from the sunlight and the water that's inside your mitochondria. So I mentioned earlier, the heart has, a lot of mitochondria. How much? Maybe between 3,000 and 5,000 mitochondria per heart cell. So photomodulation may help with that. You can treat the sternum and activate stem cells, and the stem cells can also help the myocardium that's been injured. So there was a study done in Israel showing the safety and feasibility of using photomodulation in somebody actually having a heart attack. They were treated with standard of care. The patients got balloon angioplasties and stents, but half the group got laser therapy during the case. 1 day later and 3 days later, they used 808 nanometers of light. So this is why photobiomodulation is slightly complicated, because you need to know what wavelength of light was utilized. So not all the over-the-counter consumer, panels work the same. So you have to know this number. You have to know the power of the device. That's known as the power density or the irradiance. So how many milliwatts per centimeter squared of light is coming out of this device? And then how long do you apply it for? So it's kind of like a recipe. So, or you're cooking something. So they were using the light for 100 seconds. The fluence is basically the dose. The person got 1 joule per centimeter squared. So they did that again when the person was admitted having the heart attack, 1 day later, 3 days later. The patients who had gotten the treatments had smaller rises of the enzymes in the blood that indicate that heart attacks were less severe. Now, I believe it was at 9 months, the heart function was the same in each individual. So it didn't have, a major change in the person's outcomes. So it wasn't like more people died who didn't get treatment, but it was at least a pilot study shows that it was safe, and there's at least a theoretical benefit for using light therapy to stimulate heart function. So this is me being a biohacker, getting IV blood irradiation. So fortunately, I don't have any cardiovascular issues at this time, but I wanted to know what this was all about. So one of my friends in St. Louis has this device, so I signed up to be a guinea pig for it. So it kind of looks like a lightsaber in my arm. I was getting red spectrum of photobiomodulation injected into my venous system. I did feel like I could run through a wall for about an hour after this. I had a lot of energy, but the energy wore off, by the next day. But photobiomodulation, has some benefits. It's often utilized in patients with chronic infections and cancers using photodynamic therapy, where they give the person an agent, either oral or IV, that cancer cells tend to uptake, and then use the light therapy to increase oxidative stress that may help shrink certain cancers. So there are some use cases for it, but it is on the banned list by a lot of the Olympian boards. So there was a handball team a couple of years ago that got in trouble for using these IV blood irradiation devices. So you can use sunlight as heliotherapy. You can use the photobiomodulation panels, and you're not going to get yourself in trouble. But if you have an IV and they're doing this light therapy, it's often banned. But if you're going to do it, typically you need to use 5 milliwatt lasers, If you really have a major issue, you're going to be doing this at least 3 times a week, and then they will slowly titrate up from 50% of the power all the way to 100% of the power. And they usually start with the 635 nanometer wavelengths. There's other colors that can be utilized depending on what the treatments are, but most of the time you're going to be using red or infrared spectrums first. So something that's relatively new to the market are these more wearable patches. So if you have musculoskeletal injury, you can slap this on the injury, and the little battery pack fires up the light. This has a pulsation feature, so you can pulse both red and blue light. The blue light can help pulse nitric oxide out of the microvessels a little bit better. So there was actually a study that they did with this device where some, quote, healthy volunteers decided to stand in front of a tennis serving machine and take I think it was an 80-mile-an-hour serve right to their quadricep, caused a perfect circle bruise in the quadricep. So again, half the people got regular treatment, just ice. Half the people got to use this device. The people that got to use this device, I believe, is up to 40% less bruising at day 1, and then the pain levels were significantly decreased. So I carry this in my kind of go bag when I travel. So if there's any type of musculoskeletal injuries that I sustain when I'm out and about, I have access to one of my light panels. So in my office at Apollo Cardiology, I have this beast of a photobiomodulation panel. This is known as the EMR Tech Firehawk, designed for Duncan Clark of the Blackhawks, who's a very tall hockey player. So I'm nowhere near tall as this gentleman. I'm probably 5'10" on a good day, and this panel is 8 foot tall. So these little bigger lights are his meridian points. But this has 3 different spectrums of light, 2 red, 1 infrared, and it throws out a lot of irradiance even across the room. So you don't need much time in front of this device. But I use this device in my office to teach patients about photobiomodulation, and then I'll send, if they have any musculoskeletal injuries or surgeries and they want to heal up faster, they can come by here and utilize it. So this is what I tend to use, is my big red light. So if you're interested in learning more about photobiomodulation or subclinical atherosclerosis, or how I kind of address dyslipidemia, high blood pressure, you can follow me online at Instagram. It's at Dr. Twyman. And I also have multiple of my videos on my website, drtwyman.com. So I thank you guys for your time and attention today. Take care.